1 in 4 people will have a stroke at some point in their lives. And over the course of this episode, 6 to 8 people will die in Spain as a result of a stroke.
In 20% of cases, the cause is unknown.
A stroke is sudden, dramatic, but largely preventable. In fact, 9 out of 10 can be prevented.
But now it's clear that being sedentary itself, even if you exercise, is an independent risk factor.
Having a stroke is a turning point in your life, and although there's always a lot of emphasis on early detection, today we're taking a step back. Prevention while you're still healthy.
1 out of every 6 strokes is due to pollution. 1 out of 6, 1 out of 6. That's shocking.
What can we do to avoid being part of these statistics and avoid having a stroke?
We are seeing an upward trend in the incidence of strokes among young people.
Today, Alejandro Fuerte Ortigon, a neurologist with extensive experience in managing cerebrovascular diseases, explains it to us. This episode is your life insurance for your brain. Welcome to Mejor que Ayer, Dr. Fuerte. Welcome, Alejandro. How are you?
Very well. Thank you very much for inviting me. I'm very happy to be here.
Thank you for talking. As I mentioned off camera, stroke is the most important topic in your specialty due to its consequences and prevalence, right? Yes. So today is going to be a masterclass on stroke, a special episode dedicated to it. It's going to be useful for people who have had a family member, a friend, or someone close who has suffered from this serious problem, but also for all of us who fortunately haven't experienced it but want to prevent it, right? In fact, we're going to focus on prevention. So to start, can you clarify the terms for us? What is a stroke? What is a thrombosis, an embolism, a hemorrhage? People get confused.
Yes. The truth is that many times we talk about stroke and people don't really know what it means. Well, stroke is the general term. It's, let's say, a focal vascular problem in the brain. Okay? It would be like a heart attack, but instead of happening in your heart, it happens in your brain. It's the general term, okay? Then, within strokes, there are ischemic ones, which is when an artery gets blocked, and those are the most common, about 70 to 80%. The hemorrhagic ones, which is when an artery ruptures, that would be about 20%. And then in a very small number of strokes, which are due to a vein thrombosis, that's something much more specific and much less common. But basically that's it. Stroke is the general term. Ischemic strokes are when an artery is blocked, and hemorrhagic strokes are when one ruptures.
Okay.
And a DERM is what people commonly call a hemorrhagic stroke, a bleed.
An artery ruptures.
And blood enters the brain. People often call it a deraim, but it's actually a hemorrhagic stroke.
And what about an embolism?
Well, look, an embolism within ischemic strokes, which happen when an artery gets blocked, there are different mechanisms. An embolism is one of those mechanisms. It would be around 20 to 30%, for example, that are due to embolisms coming from the heart. Another type of stroke is caused by carotid artery plaques. Another type of stroke, the most common one, is caused by long-term high blood pressure.
That originate in the heart, meaning the clot forms there and then travels out.
And is sent upward. An embolism is a traveling clot. It forms in the heart, then travels to the brain.
Great, perfect. And it's true that the brain doesn't feel pain, right?
Exactly. Yes, the brain doesn't feel pain. In fact, many surgical procedures are done with the patient semi-sedated, and different areas can be stimulated to observe the brain's functionality. What happens? Even though the brain doesn't feel pain, there are some strokes that can affect the meninges. The swelling from a stroke affects the meninges, the layer covering the brain. And the meninges are richly innervated with pain fibers, and they do hurt in that case.
So there are strokes that can be painful?
They can be painful. Ischemic ones hurt a little, about 10%, especially when it happens here in the posterior region, because it's very close to a part of the meninges that goes inward, that is, that goes inside. Hemorrhagic ones tend to hurt a little more because intracranial pressure can increase, and in the end, the pressure pushes against the meninges and it hurts. And then there's a type of stroke that hurts a lot, which is a subarachnoid hemorrhage, when there's blood in the space between the meninges, between the layers, and that one really hurts a lot.
Because it really stretches the meninges?
That's right. It affects the meninges, irritates them, and irritates the blood vessels.
Okay, so it really hurts because of the meninges?
Because of the meninges?
But the brain itself, no?
It doesn't hurt? No.
Okay, interesting. Hey, and is it true that a young person can have a stroke?
Yes, it's true. In fact, that's what concerns us the most right now, because we're seeing an upward trend in the incidence of strokes among young people.
And what is that due to?
Well, that's a good question. What we're seeing is that traditional factors are more common among young people than they used to be in the 90s, for example. Now we're seeing, for example, more people with obesity between the ages of 20 and 45, with more diabetes, sedentary lifestyles, and that causes the incidence among young people to increase a bit. In fact, when I compare what I see now to what I saw when I started, I do notice a trend of younger patients coming in with a stroke. So yes, then there are non-traditional factors which are also typical in young people.
But speaking as a layperson, the use of certain drugs also increases the risk of strokes in young people, yes.
Exactly, especially cocaine and methamphetamine.
It increases the risk.
Very typical. Patients even come in after just one night with
And when you say younger, what ages are we talking about?
up to 50, between 15 and 50 years old.
Of course, because a stroke was usually seen in people over 60.
Yes, these were mostly seen in young people before, but now they're more common. We're also better at detecting them now. That's true. Now, when a patient has some kind of symptom that doesn't quite add up, we think about it. For example, a patient who comes in with a migraine and a strange symptom. Previously, we didn't do MRIs, but now we do, and we find small cerebral infarctions. Detection is better thanks to more tests, which could also explain it. But definitely what has increased, and that's undeniable, are the risk factors in young people.
Okay. What's the likelihood, Alejandro, that a stroke could kill you?
That a stroke itself kills you, about 10%. Even in Spain, 10 to 15%. How would a stroke kill you? Well, if a very important artery in the brain gets blocked, which is the basilar artery located back here, and it supplies areas responsible for breathing and heart rate, and hemorrhagic stroke, and massive hemorrhages, ones that are very, very large and cause the brain to be compressed, herniate, and compress the brainstem, leading to death. But that's rare. The main problem with strokes that we see are the after effects, the deficits they leave behind.
Right, of course, that's probably what worries people even more, yes. Let's go into explaining those after effects, the most common ones, and then I'll ask you about one that has a strange name. Okay.
Perfect.
Very good. Which are the common ones?
Well, look, the most common ones are the ones we don't see. They're the invisible ones, as we call them, which are fatigue, depression, headache, brain fog.
Is depression a consequence of stroke?
Yes, from stroke. Yes, it's common. I don't know the percentage, but it's seen often and rarely treated.
And mechanistically, what is it due to?
Well, I think it's because of the shock. Probably from, I don't know if it's some organic mechanism, honestly, but I think the psychological shock of suffering a stroke and losing functionality, I think that has an important component, and we see it quite a lot. In fact, now the guidelines recommend that patients with depressive mood start antidepressants as soon as possible, even while they're still hospitalized. So yes, depression does happen. Mental fog is also very common. Lack of focus is common. Some cases are obvious and measurable, which is what we as doctors assess because they're visible. Well, there are also studies, of course, on fatigue and brain fog, but the ones we usually measure are the most visible, which are loss of strength, loss of sensation, speech disturbances, and vision problems, which are the most common.
To what extent can strength be recovered, for example, in a limb?
It seemed...
Right, correct.
That's it. Well, look, it can be recovered. I think that's quite a lot. I don't remember the exact number of patients who recover 100% right now, but patients who recover enough functionality to do something with that limb, I think it's around 40%. So that's not bad.
Yes, half.
Yes.
I mean, and 60% don't regain functionality in that limb.
60% don't, but it was worse before. That's why I'm saying it's not bad.
And what does it depend on, whether they do or not?
Well, look, early treatment, early identification, and then having a good cerebrovascular system, which is what we're going to talk about later, which is how to get more collaterals, which are the arteries around the blocked artery that can help that area. It also depends on neuroplasticity. People with a healthier lifestyle will have more neuroplasticity. Young people have more neuroplasticity. It depends a lot. I've even seen cases very similar, two patients where one recovers very well and the other doesn't recover as well. I mean, it really depends a lot on the person. It also depends on motivation, on rehabilitation, on addressing those symptoms we often don't see, like depression, which can cause the patient to go out less.
Exercises less, gets less rehabilitation, right? And then there are other consequences that are less talked about, like anosognosia, which is that.
Yeah, well, anosognosia is very interesting. Every time I see it, honestly, it's fascinating. One of the reasons I chose neurology. And it's the brain's inability to recognize a deficit. That's what it is. And we see it a lot. Patients who maybe come in with, it's very typical of right-sided brain lesions, right frontoparietal lesions. The patients have a motor deficit due to the frontal involvement, and then they have, due to the parietal involvement, that anosognosia. And it's, let me give you an example so you understand it well. A typical patient who comes to the ER and clearly has a deficit on the left side because the brain injury is on the right, the wiring is crossed, and they have a deficit on the left side. And you ask them what's wrong, and the patient tells you nothing, that they're perfectly fine, that they want to be discharged, even though they clearly have a deficit on the left side. You show them their arm, you take their left arm, show it to them and say, well, you can't move this arm. They say, no, but that's not my arm, that's yours. Really? Yes, really. It's curious. He doesn't recognize his arm or that deficit. When told it's his arm, he replies, if you say so, it must be mine. I say, let's see, lift it. The patient doesn't lift it and changes. And when you ask him again, you haven't lifted it. Yes, because I don't feel like it or because I'm tired, but I want to be discharged because I'm perfectly fine. And that's when the family starts to say, but how can you say that if you clearly can't move the left side of your body? I mean, it's very curious. He doesn't recognize it. He doesn't recognize it. He doesn't recognize it. What happens with this? Imagine a patient who doesn't recognize their weakness, who will stick with rehabilitation. Sure, they'll have very little, and that's the issue.
Because this isn't just in the acute phase, it goes on.
It goes on. It's true, it often improves more than strength. But of course, in the acute moment, after those 24 hours when we start rehabilitation, if that patient doesn't recognize that they have a deficit, how are you going to rehabilitate them? It's very difficult. Neurorehabilitators have their techniques, which I honestly don't really know about, but the truth is that it's really fascinating. Yes.
And we can have a stroke without realizing it. I mean, there are silent strokes that we don't even notice.
Well, yes, we definitely can have one. In fact, it's seen quite often. A typical MRI that you order for a patient because of a headache, well, for head pain or some other symptom, where you don't expect to find a stroke, and there it is, a stroke in a deep area of the brain. You ask the patient about symptoms, and they say they haven't experienced any. And why can this happen? Why hasn't the patient experienced any symptoms? Because the stroke occurs in an area, in a non-eloquent area of the brain, which has little, let's say in quotes, importance. That's it, importance. It's not a stroke that affects the language region. Why does it happen? It's due to the same factors as a regular stroke. It has been observed that after surgeries, all kinds of surgeries, small strokes can appear on the MRI. Especially surgeries, as you can imagine, heart surgeries, valve replacements, also, I don't remember which one, another one, bypass. It's common to have small strokes, but they're usually so minor they don't impact brain function. And it's a complication that's rare, but of course I'm biased because I see it, because they call me for those strokes, but it's rare.
And TIAs, yes, this is like, yes.
Well, it's not the same, it's not the same. TIAs are strokes that the patient experiences. Yes, they really experience them, but the patient improves in less than 24 hours. Why do they happen? Well, it's believed that they happen, or that the vast majority of TIAs are due to a small clot. It's due to a small clot that forms. Well, normally they tend to be emboli that come from the heart, but a small clot can also form in the brain, and for whatever reason, that clot has broken down or has migrated to other, more distant regions. So the patient gets better. What happens? We used to think that TIAs were mini strokes that didn't leave any lesions. Now we do MRIs on them, and we see that even though the symptom has passed, many of those patients have lesions on the MRI. So now we diagnose them with stroke. Practically, it doesn't matter to me if they've had a stroke or TIA, since treatment and prevention are the same. You must take it seriously. That's why we've reduced recurrence. Or the appearance of a stroke after TIAs, because we're very aggressive about it. We do tests, treatments. Of course,
If someone has a TIA, it means they are at high risk of having a stroke.
that's right. It was 20-30% in 3 months. Now it's just 5%. We've reduced it significantly over the years thanks to the treatments. Thanks to the treatments, now we quickly do an CT angiogram, which is the test to see the arteries, or a Doppler. We also do lipid tests, glycated hemoglobin, CRP, all of that. We do it and see why. We also do an echo, a Holter many times, and we see that maybe we have a fibrillation. Atrial fibrillation And if we had discharged that patient, maybe they would come back in 2 weeks with a stroke.
All right. When a person has a stroke, for example, in the language area, the brain can, in other undamaged areas, take over language functions and recover certain abilities, can't it? Each area is kind of limited to what it does, and that's it.
Yes, it has been observed. Yes, an area near the language center, if it has healthy neurons, can acquire that function. But it's true that it's very little. What has been observed is that more than the function itself, the number of synapses increases and the blood flow to that area increases, let's say, to improve neuroplasticity. But it's true that we are, I think that would be the great milestone of neurology, which is to improve deficits. Much more, whether it's by increasing neuroplasticity with factors, let's say, of neuronal stimulation, of neuronal growth. We still have some brain stem cells as adults, right? And I think that should be, well, in fact, there are areas of research. There are even areas of research with stem cells, actually. But for now, everything is still in its infancy. They can take over the function, but only to a very limited extent.
Okay, of course. All right, there's also another word, cryptogenic stroke. What is this?
Yes. Well, crypto means unknown, unknown origin, and a cryptogenic one. It's a stroke that we have, and after doing a huge investigation on the patient, the typical ones we do for vessels, heart, a panel, we don't see the cause of the stroke.
That's possible. It may not be visible, yes.
In fact, in about 20% we don't know the cause.
1 out of every 5.
1 out of every 5, especially in young people. It's very typical. A young patient where we don't know the cause of the stroke.
This is serious. Nothing shows up in the arteries. You don't see anything.
You don't see anything?
The brain is dead. A part of the brain has died. I mean, it's something very...
Well, there are many theories. There are theories that say cryptogenic strokes are due to atrial fibrillation that we haven't detected. And there are others that say all the factors have an influence. Even if it's just a little, even if it doesn't reach the pathological threshold, having a bit of each thing has an influence. The fact that I have a carotid plaque, which, for it to be considered symptomatic in theoretical terms, must be large and cause a hemodynamic alteration of the flow. But maybe I have a very tiny plaque that can cause a stroke. Then there are atypical factors, like stress. It has been seen that patients with a high level of stress, even if we don't talk about it, can also be at risk of stroke, but then we don't see it in any test, because how do you measure stress? Of course, and then people often don't even ask themselves about it.
Sometimes they don't even mention it.
Of course. And what about cryptogenic strokes? Honestly, it's frustrating because you're left with the uncertainty of whether to give this patient preventive therapy. What I have to do is monitor them very closely and optimize everything I can. The risk factors really push for a healthy lifestyle, keep investigating and keep following up with them. We need to keep following up with these stroke patients because symptoms might not appear immediately, but can show up after 6 months.
Okay. What is the prevalence, at least in Spain, of strokes or cerebrovascular accidents?
Well, look, the general prevalence is that 1 out of every 4 people will have a stroke. That's about 20% over the course of their lifetime, starting from age 25. So 1 out of every 4 people is going to have a stroke at some point.
And then TIAs count there too?
TIAs are included there, of course. TIAs are included there, yes. But of course, in the end, stroke is the leading cause of death in women, if I'm not mistaken. At least it was until 2021. I mean, it's quite striking. I mean, of course. And then about the numbers. I think in Spain there are about 120 or 130 or 140,000 strokes per year.
I mean, a lot. I saw a statistic that said there was 1 every 14 minutes, more or less.
Yes, possibly, yes.
So basically someone already had a stroke during this episode.
Yes, because I think about work. When they call me during my shift, I think about all of Spain and its hospitals and say, yes, it's possible, of course.
Getting into prevention now, Alejandro, which if you had to name one, I don't know if this is possible, but what is the most important risk factor for having a stroke?
Sure, I'll tell you one that's well proven, high blood pressure.
High blood pressure is the main enemy in stroke.
The worst. More than 50% of strokes are due to high blood pressure.
Both ischemic and hemorrhagic?
Exactly. In hemorrhagic cases, there is a clear relationship. Patients with hypertension can have a spike and an artery can bleed. Ischemic cases often involve both acute and chronic hypertension, though acute hypertension can also occur in hemorrhagic cases. The fact that this patient has had hypertension of 160, 170 throughout their life or for many years will eventually end up with a stroke. And honestly, it's very striking because these are the patients you see in the hospital and you think this could have been prevented because treating arterial hypertension. We have so many medications, I don't even know how many, but a lot. This lifestyle, even measuring blood pressure, many people don't check their blood pressure. Or they see a doctor or go to a pharmacy, get checked once, and are told it's fine, 125. They go home and don't know that, for example, at night they have spikes in blood pressure, or for example, around 8 in the evening or mid-morning they have blood pressure spikes. That's why you need to measure your blood pressure a couple of times a day, at least once or twice a year if you're not hypertensive. That's why, because it's really frustrating. You see the patients and you think, this patient who came in with this kind of blood pressure of this magnitude could have been managed earlier.
And the brain is more sensitive to blood pressure for some reason. I mean, it strikes me that it's even more important than dyslipidemia, cholesterol, stress, or smoking, right? Which is a major risk factor, that hypertension is the most powerful one.
Well, yes, because it's been seen that there are some very tiny arteries in the brain called perforating arteries, which are very, very small, but they're very important because they supply the areas responsible for movement. Yes, and it's seen that when someone has chronic hypertension, those arteries start to remodel, and the endothelium, which is the inner layer, gets thicker, and eventually they get blocked. So that actually has a name, which is lipohyalinosis, and it's mainly caused by high blood pressure. When you add factors like dyslipidemia and smoking, it creates a harmful mix. If you wouldn't have had a stroke at 60, that combination could cause one at 40.
Right? Okay, I understand. Is tooth loss or poor oral health a risk factor?
Yes, and I was really surprised when I read about it. There are observational studies that say, that conclude that patients with poor oral health, periodontitis, or tooth loss have a higher risk of stroke. However, the authors themselves later say that it could be an association and not causation, that patients with periodontitis eat more ultra-processed foods, take less care of themselves, and control risk factors less. They are also patients who clearly have a higher risk of stroke, but the plausibility, let's say the biological causality, exists, because in the end it does give you an increased risk of stroke. Chronic inflammation, and that periodontitis, has been shown to increase markers of chronic inflammation in the body, CRP and other markers. And then DNA from bacteria that we have in the mouth has been found in carotid plaques. So, let's see.
Bacterial DNA from the oral microbiota.
Yes, it's not that the plaque causes it, but it's already clear that what happens in the mouth has, let's say, some kind of effect or impact at the systemic level. There is a clinical trial. I don't remember how many patients they included in the trial, but in patients with stroke and periodontitis, they randomized them. In patients with intensive oral hygiene and patients with normal oral hygiene. Well, of the two groups, the one with more intensive hygiene improved their metabolic and inflammatory markers. I think blood pressure and I think dyslipidemia improved a little, but it didn't reduce the risk of stroke. But of course, that doesn't mean anything. It just indicates, maybe I don't remember the size of the study. Maybe it was too small. I don't remember. But I think that biologically, it makes a lot of sense. And besides, it's something that's so easy to prevent. It's just oral hygiene.
But remember, the same thing happened at the cardiac level, right? In cardiology, it also increased the risk of heart attack, basically. Great.
Well, then, of course.
Well, that's it then. And regarding environmental pollution, which is a hot topic right now, does living in a polluted city have any relation to this? It could be Madrid, it could be Barcelona, Tokyo, Japan, many places. And what about the risk of heart attack?
Yes, quite a lot, actually. There is a study called Interstroke, which is an epidemiological study, that concluded that 1 out of every 6 strokes is due to pollution. 1 out of every 6. And then you look at the WHO statistics, and it says that 95% of the human population is exposed to higher than recommended levels of tiny particles. Of course, then you think about why pollution can increase your risk of stroke. But then if you think about tobacco, in the end, pollution would be, roughly speaking, like passive smoking. Pollution, those particles, what they do is enter your bloodstream through the alveoli. They're so tiny that they pass through, and what they cause is damage to the endothelium and then inflammation, systemic, and also an increase in arrhythmias and blood pressure. So yes, in fact, it has been proven that during peaks of high pollution, there are more hospital admissions due to stroke and higher mortality from stroke.
So you can establish a correlation between, times of the year when there is more pollution and more strokes. Yes, stroke. That's intense because it's also something that, unless we maybe wear masks, right?
I mean, look, the other day I was talking with a colleague who works in preventive health. We were talking about masks. And of course, how are you going to get people, after what we went through with COVID, to put on new ones, people who don't?
No one would follow it, of course.
But look, what I'm recommending to patients who live in urban areas are HEPA filters, to have them at home, because they filter these tiny particles, and in the end, you spend most of your time at home. I mean, it's a filter you can buy on Amazon. I don't know, it costs about 50 or 60 euros. And what it does, what has been shown, is that this filter reduces inflammatory markers. There's nothing proven that it reduces strokes, but it's the same idea. If you can afford that filter, it's probably a good idea to have it at home if you live in the center of a big city.
Of course, super interesting. And in terms of nutrition, which is something the audience of this channel is very interested in, is there any diet or dietary pattern that studies show is best for stroke prevention?
Here, it's just like with cardiologists, the Mediterranean diet. It reduces the relative risk of stroke by 20%, and it's about legumes, nuts, vegetables, fruit, the same as what all the guidelines actually recommend, right? From endocrinology as well, in the end, there's really no doubt about it.
Is there any element of the diet, any micronutrient, any mineral? I understand that sodium is also very important here, right? Because of what you mentioned about high blood pressure.
Exactly, yes. The sodium that we end up consuming comes from ultra-processed foods, so in the end, the table salt doesn't really have much of an impact. But it is possible maybe to recommend to patients that instead of taking 100% sodium chloride, they take 75% sodium chloride and 25% potassium chloride. There is a study in China that also reduced the risk of stroke in this type of patients. So, that can be recommended instead of that type. But in the end, salt, I think that here in Spain, in the Western world, we consume it with ultra-processed foods.
Mainly ultra-processed foods, of course.
Then there's another type of diet called the DASH diet, which is the one for...
I laugh a lot.
Also. Yes, right? It's the one that's also highly recommended. And then, if patients have a very bad lipid profile, really bad, and they don't want to take statins, and they're in primary prevention, without anything having happened to them, the portfolio diet, which is very rich in vegetables, reduces LDL by about 15%, 20%, I think.
All right. What role does exercise play in the prevention of a stroke?
A lot. It's fundamental. Exercise, both aerobic and weight training, but especially aerobic exercise, what it does is improve things, especially at the brain level. Markers of neuroplasticity in the brain increase. Collateral vessels in the brain also increase, and in the end, exercise improves low-grade chronic inflammation. Insulin resistance. And now the guidelines are starting, not just starting. For a few years now, they've been recommending weight training, strength training, because it also greatly improves insulin resistance and prevents sarcopenia.
Yes, functionality as well. That's right. I imagine that someone with a strong muscular system also recovers better after having a stroke.
Exactly, right? Yes.
Right, so every bit of exercise, especially aerobic exercise, also helps with long-term stroke prevention.
And one thing I didn't know that I was looking into, I don't remember how long ago, but it's about being sedentary, because honestly I thought that patients or people who exercise for an hour a day or who meet what the guidelines recommend, which is 150 minutes of aerobic exercise and weight training twice a week, that they were covered. But now it turns out that being sedentary itself, even if you exercise, is an independent risk factor, which really caught my attention, honestly. So now what is recommended is that if patients have to be in the office sitting for 6 or 7 hours every 30 to 60 minutes, they should get up or buy those desks that allow you to work standing up.
Yes, break up continuous periods of being sedentary. That's it. Try to break it up every, like you said, 60 to 90 minutes. But it's true that it's very common to sit down at 8 and not get up until 3, right? Sometimes doctors who have to do rounds and so on don't.
But it's actually happened to me.
To me too, in the office.
Yes, you have to remind yourself many times to say, of course.
Or sometimes I would go get the patient, go out, pick them up, right? It was a way to force myself to get up because yes. And a very important topic, palpitations, right? Because, well, palpitations in general are a very common symptom, but in neurology, when is it important not to overlook them?
Well, look, especially in people who have neurological symptoms along with palpitations, obviously, patients who have palpitations and also have some kind of dizziness or even neurological focality, which could be a stroke, right? Problems with speech.
Focality refers to those symptoms, correct?
Focal symptoms are neurological symptoms. And then patients who have had a stroke, who are not diagnosed with an arrhythmia, and who start having palpitations. That patient needs to tell the doctor as soon as possible, because it could be that atrial fibrillation, which is an arrhythmia associated with stroke, is present in 20 to 30% of stroke cases. Well, it may be showing up much more than before when the stroke happened. So patients who have had a stroke and start experiencing palpitations, that's something to keep in mind. Or patients with many risk factors who also start having palpitations that last for a while, not just a single beat or a sudden extra beat, but palpitations that last for quite some time. And I think that's basically it. And then patients who have symptoms from the palpitations themselves, like chest pain, shortness of breath, and so on.
And let's remember that AF, atrial fibrillation, was dangerous because it increased the likelihood of blood clots forming, right? Which can travel upwards, right? Yes, and reach the brain. That's it. Okay. And are there imaging tests that can predict my risk of stroke if I've never had a stroke before, that is for primary prevention?
Well, yes, there are. Look, with an MRI, if you have a lot of white spots, many old strokes, even if you haven't had any symptoms, your risk is already higher. And then there's a test that we sometimes do, which is a neck ultrasound to look at the carotid arteries. There's a lot of controversy here, okay? In fact, the guidelines don't recommend it for all patients, and I'm always very careful about who I order it for. What's going on? Until very recently, the evidence we had was that patients without a stroke but with plaques in the carotid arteries receive medical treatment, but they are not intervened on. Now we have a fairly recent study from this year that tells us that patients with more than 70% narrowing may benefit from a stent, which is the metal mesh, or a carotid intervention, surgery, especially the stent, the metal mesh.
What happens? A carotid surgery? It sounds difficult, it sounds complicated, doesn't it? Yes.
Yes, but don't think it has more risk than a metal mesh, because it depends on the patient and on the team of surgeons, it depends on the team of interventionists, it depends on the hospital, and it depends on the patient's risk. Many times, patients, for example, who have a lot of calcium, well, you can't put a stent in that patient, so surgery is used instead. A lot of calcium because in the end, it's like what happens with the heart arteries. In the end, the carotid arteries end up becoming calcified.
And from my absolute ignorance, how do you operate on a carotid artery with such a strong blood flow, right? Yes. Well, just saying, I imagine it's like a butcher shop there, as if...
That's done by cardiovascular surgeons, but yes, what they basically do is clamp the artery. The artery... They remove the thrombus. And honestly, I've seen very few complications. In fact, the complications I've seen have always been very mild and localized. Maybe because when touching the neck, they damage a nerve in the face and the face droops a little, but just a little. And with the stent, it's the same. Honestly, these are procedures that, when well indicated and with a good team, really are safe as well. What happens is that now we have this study that's telling us to be careful, because the stent can even be placed in asymptomatic people, depending on the degree of carotid narrowing. Before, honestly, I didn't refer anyone for intervention, but now with this recent study, I really think carefully about who I can refer for intervention or not. And then medical treatment, 100%, obviously.
I once read something about what they called the beauty salon stroke or something like that, right? Can you have a stroke from extending your neck?
Yes, but it's very rare. I've never seen a case. I looked into that too. There are very few cases described. It's definitely possible, but it's extremely rare. I've never seen any. Honestly, it's not something I would have to deal with.
Is due to a carotid dissection
A vertebral artery dissection.
of the vertebral artery.
We have two carotid arteries here, for people who might not be familiar with anatomy. Two carotid arteries here and two vertebral arteries in the back. And the vertebral arteries are very susceptible to tearing, to having some kind of tear, because they run inside bony channels. Of course. So any sudden neck movement, sudden hyperextensions, especially, it's very typical in people who have had trauma, right? Those who don't wear a helmet often end up with arterial dissections. And especially movements where you aren't being held. For example, the times I've seen dissections in young people, it's been people who weren't careful. And maybe doing something silly with a massage or something, someone cracked their neck.
And be careful with that, with those massages out there.
Without having, yes, I have. I always tell them to be careful with that kind of thing.
Is stroke risk higher for patients who snore?
Patients who snore and have apnea are at higher risk for stroke. Apneas are, in the end, breathing problems during the night, and it has been seen that patients with apnea have a higher risk of stroke for many reasons, because it increases blood pressure. Of course, blood pressure naturally drops a little at night, about 10 to 20%. People whose blood pressure doesn't drop, be careful because it could be sleep apnea. Also, sleep apnea causes more vascular inflammation, insulin resistance, atrial fibrillation, hypertension, a lot of things. Oxygenation to the brain even decreases during apneas. So yes, it definitely increases the risk of stroke.
Yes, these patients typically face very high cardio and metabolic risk for several reasons.
Yes. They are patients, but I think we do little screening for apnea. I think we rarely check if the patient has apnea or not because, I don't know, maybe it's a risk factor that's not taken into account much, or maybe the patient doesn't mention it.
Or lives alone.
Lives alone, that's true, of course. Lives alone, so it's not known if they stop breathing during the night and so on. But yes.
And another factor that can now be linked to almost any disease is the microbiota. Have you read anything about the relationship between cerebrovascular health and the microbiota? Yes.
Yes, I have read something, but there isn't there is a relationship. It seems that there is a metabolite that the microbiota, when it's missing or when it's altered, can affect the endothelium and may theoretically increase the risk of stroke. I haven't seen any study showing that changes in the microbiota raise stroke risk. I think it's probably because of the issue of systemic inflammation, intestinal permeability, probably. What has been seen is that people who have a stroke have their microbiota altered. The gut-brain relationship is bidirectional. It's bidirectional. The direction is very clear. And then, for some patients who have chronic inflammation, I also sometimes recommend fermented foods because they reduce that inflammation and improve inflammatory markers a bit. There is a study, I don't remember which one right now, but in patients who consumed fermented foods frequently for 10 weeks, their inflammatory markers decreased. But nothing has been proven regarding stroke and the microbiota. But well, it makes a bit of sense. It's true that I obviously wouldn't put it at the same level as hypertension, smoking, and so on. In the end, if your microbiota doesn't cause a stroke, it'll cause something else.
Always an intermediary. In the end, I think in the pathogenesis of any chronic disease, there will be one.
I'm not sure if that's true in cardiology either.
Also, if there's quite a bit of relation, there's quite a bit of relation. A risky behavior that's very much on the rise and is very concerning is the use of anabolic steroids, usually for aesthetic or performance purposes. They're related to stroke because they're closely linked to the heart.
Well, the same. The same. There are no clinical trials, obviously, but there are studies, some really impressive case studies. I've only had one guy who was taking anabolic steroids. Well, more than anabolic steroids, I think he was taking clenbuterol, which I think causes arrhythmias, some kind of arrhythmias, and he had a stroke.
I think it's a beta agonist, right?
A type of arrhythmia, but yes, of course, there are cases. If you Google it, you'll find a lot of cases. Why? Well, because they alter the whole metabolic system. It raises hematocrit and platelet aggregation, and it contributes to inflammation, hypertension, arrhythmias, and heart disease. In the end, yes.
You have to ask as well.
Yes. And another thing that people rarely ask about. Yes. I know, you have to ask, because you'd be surprised, of course, people.
Of course. And out of the people you ask, about 10% at most will say yes. They'll admit it. In the end, since it's such a taboo subject, yeah. Chronic stress, burnout, like you said, this fast-paced life, it's very hard to measure. Sometimes we don't realize we live that way, right? Because we normalize it, or that it generates stress, or let's say, well, something negative in your body. Sometimes we just normalize it. We normalize it, but it's also a risk factor, as you said. Yes.
Exactly. Yes. A risk factor that we are giving more and more importance to, especially in young people in the working stage because of the load of hours. There is a relationship between the number of hours a person works and the risk of stroke. There is a relationship between chronic stress and the risk of stroke. Currently, there are no clinical studies on this relationship since it's impossible to control, but there are observational studies. And epidemiological studies indicate stressed people have a higher stroke risk, either directly from chronic inflammation, arrhythmias, or hypertension, or indirectly since stress leads to neglecting self-care. That's right. So yes, definitely. And in fact, I have patients with cryptogenic stroke who had extreme stress the week before, work problems, the death of a family member. So I mean, maybe that's what's behind it, some kind of cardiomyopathy like Takotsubo, or maybe a spike or some AFib, some atrial fibrillation that we miss, spikes in blood pressure or something like that.
Have you found that in those patients where the origin wasn't known, they did have very stressful events? Some of them,
yes.
Let's see that, but that's something you have to ask about. I also like to ask about it in autoimmune diseases. For example, in Graves' disease, hyperthyroidism, right? Which is also very related to stress. For me, I noticed that maybe other colleagues didn't ask as much. They didn't dig into that, but I was interested because if you ask, you'll see that in the weeks before the diagnosis, there's always something.
Right. Yes, that's true. We probably need to investigate that further. Honestly, in some cases, I do see it clearly, but in others, of course, the problem is that you can't establish causality in that. No. You can't diagnose it as stress because that's not allowed.
Hey, and the brain does recover. Let's say there are many processes of regeneration and repair at night when we sleep. Insomnia, those who have chronic insomnia, I don't know, are at higher risk of stroke.
So yes, also yes. In the end, sleep, people who have sleep disturbances are at higher risk because of what we were talking about. It basically causes the same thing as sleep apnea. Insomnia problems, well, issues with glucose regulation and so on, which, and then that lymphatic system we were talking about, right? That it can't clean in quotes, right? Which is a bit more complicated, but the beta amyloid proteins and so on, they aren't cleaned as effectively. And that's mainly that. Hypertension too. But yes, sleeping less than 5 hours has been linked to an increased risk. Sleeping more has also been linked to an increased risk. I think that this sleeping more is just an association because there are people who sleep, they have
pressure, or they have some, I don't know, I imagine some kind of functional disability to, of course.
They sleep more and have a higher risk of stroke. So it's a non-causal association, but sleeping less, yes. Also, stress is very closely linked to that.
Of course. All right. Supplements, which is a topic that always interests people. Is there any kind of supplement? I'm thinking, I don't know, magnesium, vitamin D, vitamin K, something that you've already studied that might be interesting in terms of prevention?
Well, look, when it comes to supplements, honestly, I recommend very few to people who take care of themselves and do things right, because in the end, apart from treating actual deficiencies, there isn't much for stroke prevention. I was looking into omega-3 after the Reduce-It study, the Reduce-It, which lowered triglycerides, icosapent ethyl, and I was looking into whether omega-3 could reduce the risk of stroke in healthy people or in people with risk factors, and it doesn't reduce the risk of stroke, but what does reduce it? Well, the Mediterranean diet, which contains omega-3. I mean, I think that sometimes if we go for natural options, there's a clear connection with reducing the risk of stroke. But maybe vitamins that are, let's say, super concentrated, maybe the same thing happens with magnesium. The Mediterranean diet has a lot of magnesium because of legumes and so on, because of its function. Well, magnesium is extremely important for endothelial function. What happens? It's also unproven that magnesium supplements lower stroke risk. Then, vitamins like folic acid, vitamin B12, B6, I always measure them, especially B12 and folic acid. Because it's true that in populations that aren't fortified with folic acid, if you give them folic acid, it reduces the risk of stroke. But since we have folic acid in our foods, I don't prescribe it either unless someone has a deficiency. Creatine, there is a small study in patients who have mobility problems due to stroke. They receive physical therapy, rehabilitation, and physical therapy together with creatine, and their walking improves a little more.
Okay, due to increased strength?
Probably. So people, well, it can be.
It's true that creatine is becoming very popular in your specialty, right?
Yes, it's true. Yes.
Especially in the field of cognitive decline, but well, in the end, yes, it's true. The brain has creatine and some very interesting papers are coming out. I've recently reviewed some about creatine in the brain, right?
Yes, there are quite a few. Brain fog, cognitive decline, even some Alzheimer's patients show slight improvement, but these are small studies. Let's see if a larger study is done.
Also, it seems that the doses needed to saturate the creatine stores at the level of the brain, neurons, and glia. It's like the doses are much higher, and on top of that, they're not very easy to stick to. Because if you have to take 15 or 20 grams of creatine a day, which isn't particularly pleasant either.
Yeah.
Yeah, it's difficult, but well, in the end, it's a molecule that I always say is like a backup battery for neurons, right? Yeah.
That's true, yeah.
Of course, when the oxygen supply is cut off, it can generate a little bit of ATP in situations of metabolic stress, right?
Absolutely. I find it interesting and believe we'll have more evidence in the future.
All right, well, we've reviewed a lot of prevention topics. Now let's look at treatment, which is really, well, prevention can also save your life, but when the problem already happens, unfortunately, there are things we won't be able to prevent, right? We have to treat it, right? What is stroke code?
All right, so the stroke code is what we activate, let's say everything we set in motion when someone suffers a stroke. Picture this. A patient calls 112, paramedics arrive, and suspect the patient may be suffering. They might be suffering a stroke because they have, well, weakness in the face, speech problems, mobility issues, sudden instability, loss of vision, so then they activate the stroke code. They call the hospital emergency services and they pre-activate me. So I already know that a patient, you are on call at the hospital, I am on call of course. And I already know that a patient is coming in with a possible stroke code, so I go to the hospital if I'm off-site, and then everything gets activated. I mean, everybody knows what they have to do, the nurses know what they have to do, we know what we have to do. The patient simply comes through the door. If we can, we examine them very quickly, check blood pressure and glucose, then do a CT scan. Depending on whether it's ischemic or hemorrhagic, we follow different treatment paths.
Okay, so Meone, usually a family member, calls 112, and the patient arrives, they do a quick examination, a quick checkup, and then goes to the CT scan. The very first thing is to do a CT scan to diagnose.
Stroke care often only involves glucose, blood pressure, and a CT scan, sometimes not even an EKG.
Okay, the CT scan, which is also very quick, right? I think a CT scan, how long does it take? 2 minutes, right?
Of course, we have to do a CT scan. Now we're actually doing two besides the simple CT scan, which is to detect if there's bleeding or not. We perform CT angiography, angio-CT, to view all vessels from the aorta to the brain, then do perfusion CT to check for stroke or occlusion. How poorly or well perfused is the area that's, let's say, at risk? Okay, so it takes 5 minutes, 6 minutes, it takes some time.
Well, we're talking about time is brain, right? We always say that time, every minute, is lost brain. Okay, imagine that an ischemic stroke has occurred. What's the next step?
Well, the next step depends. You really have to individualize a lot in stroke cases. A lot. It depends on what I see in the stroke, in the CT scan. It depends on what the family member says, what the patient takes, their age, comorbidities, and medical history. Each case must be individualized, as every patient is different. But if it's within the treatment window, which is usually 4.5 hours from the onset of the stroke, although that window can be extended, then a fibrinolytic can be given, which basically activates the system we have to break up clots. Thrombosis. They're fibrinolytics, a medication, right? It doesn't take long at all. We have two. One is given by infusion, which takes an hour, and the other takes a minute, so it's pretty fast. And then, if there's a large clot, you can go to the thrombectomy room, which is where they access the artery in the brain with a catheter through, well, the femoral artery, the aorta, carotid, and they reach the artery in the brain. And with either aspiration or with what's called a stent retriever, which is a little spring that wraps around the clot and they pull, the clot is removed. That is done either by radiologists or interventional neurologists.
There is the role of the interventional neurologist.
Yes, it varies by country and hospital. Either a radiologist or neurologist handles it. Okay. Here in Spain, for example, they're mostly radiologists. In other places, it might be the neurologist.
So In ischemic cases, those are the two main things to remember, right? Fibrinolysis when the patient is a candidate, right? And, well, of course,
Everything has its thrombectomy, yes, but it's very individualized, which is where we come in. Very individualized, because sometimes patients arrive on time and for whatever reason, maybe you see a very large stroke already or the brain is dead. If you give the fibrinolytic, that brain is at risk of bleeding, so you can't give it. Or patients who are taking some kind of medication like an anticoagulant, well, you have to see whether you give it or not, depending on the risk-benefit balance. Of course,
they can bleed heavily. Obviously, you shouldn't give a fibrinolytic to a bleeding patient as it would worsen their condition.
well, look, basically you have to do 4 things. Patients who are bleeding, you need to control glucose, blood pressure, temperature, and reverse it if they're taking any anticoagulant. What happens? There are anticoagulants that we can't reverse. But basically those 4 things from my point of view. Then, if the bleeding is accessible or the patient's life is in danger, that's when the surgeons come in, which is to remove it, neurosurgery. Neurosurgery, that's it. But most hemorrhagic strokes are not operated on because they are very deep. But if that stroke starts to cause an increase in intracranial pressure and puts the patient's life at risk, or if that stroke is very accessible, then the surgeons can go in to remove the clot, the hemorrhage. But that's their field. It depends. When I see a deep stroke, I normally don't contact them unless I think the patient's life is in danger. Then they get involved.
Okay, all right. And going back to the moment when the stroke starts at home, right? There's a family there and the father is already elderly. How can the family tell the father is having a stroke?
Well, look, it starts suddenly, in minutes or seconds with loss of strength, usually on one side of the body or the other, hand and leg, speech problems, vision problems, instability. That the patient notices something is wrong with some neurological deficit, that is, some loss of physical function.
What you said is most common, loss of strength or speech.
Right? The most common thing I always see is loss of strength in one arm usually, and some loss of facial movement, where the face droops a little. And with some speech impairment, either with articulation, where they speak as if they were drunk, or with the ability to produce or understand language. That's the most typical, but like I said, there are many types of strokes, so any new deficit for the patient. If it's acute, I think it's important to seek medical advice. It's not the same as a focal deficit if the patient just feels a bit dizzy because they stood up quickly from a chair. That's not going to be a stroke. It also has to be focal and have a rapid onset.
And at that moment, when the family members witness it and interpret it as a possible stroke, is there anything they can do before the ambulance arrives? Is it helpful to give an aspirin? Is it helpful? I don't know. Can anything be done? If I have to help, say, on the train back, a patient might be having a stroke, what should I do?
Well, really, call emergency services so they can activate the protocol. There's little you can do. You can make the patient comfortable if they're sitting, lean them back a little, or maybe on the AV. In the case of the AV, it's best to lay them down a bit on the seats. Put them on their side in case they vomit, so they don't aspirate. And that's about it.
There's no intervention or medication you can give then? Nothing?
Nothing. Studies exist, but we can't give aspirin because it can cause bleeding and may worsen the situation. And then there are some studies on pre-hospital blood pressure control and they haven't shown any benefit. Even if imagine you have an intravenous drug to lower blood pressure, it hasn't been shown that lowering blood pressure improves future functionality. In fact, it could make it worse. Yes,
What matters most is the train stops at the next station, they remove him and take him to the nearest hospital.
In fact, I've had stroke cases on airplanes where there's nothing they can do. They just call airport control and that's it. The ambulance waits at the airport and that's it. They bring you quickly. You can't do anything. Okay, all right.
Okay, of course. All right, well, I haven't asked, but a stroke? Well, yes, you told me, I think. A stroke can cause a cardiac arrest when there's a basilar artery thrombosis, you said usually.
Right, that's it. Yes.
And can the patient go into cardiac arrest?
The patient can go into cardiac arrest? Yes.
Okay, then we need to do the RTP.
In that case, we would have to do the RTP, of course. Okay, it depends, of course, on the complications later. Well, I don't know, if they start foaming at the mouth, put them in the recovery position, or if they start convulsing, well, it's not that you can't, it's just that I'm thinking you can't. No, it's just that you should simply call for the CT scan as quickly as possible.
All right, perfect, okay. And regarding the future, right, you mentioned earlier that it's exciting, that there are really cool things coming, that there are some very motivating advances. Would you like to share any of what you've seen at some recent conferences?
Well, look, there are quite a few, and honestly, yes. Every time, well, this whole stroke thing has advanced a lot, because in the years, you have to keep in mind that until the 70s or so, we didn't even have a CT scan. And then fibrinolysis, which we've mentioned as the treatment sometimes given to patients, we started using it in 95, and thrombectomy has only been around for about 10 years.
So only 10 years.
10 years, yes. In 2015, the meta-analysis came out.
What was done with the patients before?
Nothing. It was simply managing complications. I mean, I think it's the most incredible advance in neurology this century, I think, unless there's another one in a few years. But it was brutal. Before, imagine patients in the year 92, well, that's it. You had a stroke, they put you in a bed, and that's it. They couldn't give you a fibrinolytic drug or perform a thrombectomy. That's how it used to be.
Villagers would say, you've been hit by a breeze. A breeze?
Of course.
A breeze hit you and now your face will stay that way forever.
That's right. You couldn't do anything. They didn't know. Even in the 60s, you couldn't tell if it was hemorrhagic or ischemic. So how could you treat it? There were strokes. Of course, just imagine that's evolving exponentially. Every year there are new things. The truth is, since I started, you have to keep yourself updated because everything is new. Now there is, for example, for ischemic stroke, for prevention, there's a new drug that seems, when combined with aspirin, it can reduce the incidence of stroke. There's been only one positive study so far, and more research is needed, though it doesn't increase bleeding risk. There are neuroprotection therapies with cold treatments, either with cold serum or cold therapy, to slightly reduce brain metabolism so that it dies more slowly while you are having a stroke. Interesting. Well, a cold serum or a cold cap?
I mean, the cold serum, cools the brain. Cooling makes the brain's metabolism decrease and the final damage is less.
It's less. It slows down a bit. The evidence is still very limited, but for example, cold is used in neonatal hypoxia, which is when the child has a global ischemic injury, meaning a lack of blood flow, or rather a lack of oxygen to the brain globally. In that case, cold can be applied and they improve. Now, in focal strokes, which is what I specialize in focal damage, so far it hasn't been seen that cold can improve the prognosis, but there are studies being done right now. It seemed abandoned, but is now being revisited. We'll see what happens. I also think that cold is also used in cardiorespiratory arrests, I believe, to reduce the risk, anything that's global, right? Global cerebral hypoxia. With focal damage, we're unsure if it works. And then another thing, thrombectomy is advancing, new devices. Imagine what I mentioned earlier about this little stent. Even smaller ones to reach even farther into the brain. Now studies are being done. Studies are being done on administering the fibrinolytic into the artery instead of through the vein after performing the thrombectomy, after removing the clot. Sometimes a little bit of fibrinolytic can be used. These are currently new studies. And then they're also doing rehabilitation therapies. Neuromodulation is really gaining momentum right now, which involves electrically or magnetically stimulating the damaged area of the brain. And there is a positive observational study. We'll see. For now, it's still very limited for me to recommend it to patients, but there are people who do it. Some people show slight improvements in language and motor skills, but studies are small and more research is needed. And I think basically it's that.
In terms of technology, artificial intelligence, wearables, I don't know, is there anything in prevention that's being applied to neurology? This is already revolutionizing medicine and will continue to do so.
Everything. I saw, last year at the American Congress, I saw a study in China that used artificial intelligence to, let's say, see if the patient has all the risk factors under control. So you enter the patient's data and it kind of gives you reminders, right? Hey, have you made sure that the LDL is at this level? Or have you made sure that after the thrombectomy you've done this for the patient? Things like that. So also in therapeutic decision making, but that's still, in the end, the role of the vascular neurologist is very important because it has to be individualized, but we'll see if AI starts to get involved there in stroke care. And then for devices like watches, apps and so on, they are being researched to see if they can detect a stroke based on movement patterns. Patients who maybe move less on one side than the other, maybe an alarm could go off there. For now, it's still under investigation. What I do sometimes recommend, because I've had a case myself, wait a moment.
I am not sure if I understood correctly. Of course, it's not about the diagnosis, but a patient who maybe imperceptibly moves one part of the body less than the other, of course, that means it's not being irrigated as well.
Exactly. That's the hypothesis. Exactly. Or imagine a patient who has dementia and who doesn't really know, who is partially dependent. Well, sometimes those patients aren't aware because of anosognosia, right? Imagine you live alone, you have anosognosia, and you have weakness in your left arm, and you don't realize it. That kind of thing, right? Motor impairment, kinetic alterations, also in bed, but it's still very, very, very early. I haven't seen anything significant so far. What I did have, as I was telling you, is that I had a case where a patient called us at the hospital after seeing her mother, after seeing that her mother had fallen to the floor. A woman living alone fell, and her fall detection watch alerted her daughter in another country. The daughter then contacted the hospital, and an ambulance was sent to the woman's home. Well, in the end, it's not just stroke patients, right? It's also older patients. Hip problems and so on, but no, it's for stroke. Then there's a study with atrial fibrillation and Yes, right? Honestly, when patients have an Apple Watch, I usually tell them to keep that in mind. The thing is, we don't know if that AFib would actually be significant, if it would be the same as the AFib we detect when it's symptomatic. It has the same potential to produce those clots. So now, they're looking into whether those patients who were detected with AFib, atrial fibrillation, have a lower risk of stroke when they're on anticoagulation. Because maybe it's an AFib, let's say yes.
Lower down, of course.
That's right.
Softer.
That's it. Okay.
It's interesting. We'll watch these new developments closely.
I'm looking forward to it. Yes.
Alejandro, it's been a pleasure talking with you. We've covered many prevention points, which was my main focus for this episode. To the audience, I recommend that you all follow Dr. Alejandro Fuerte on Instagram, mainly, right? Yes,
that's where I am.
I'm creating content there now. Because, well, it's going to focus on stroke prevention, which I think is an absolutely necessary and still little known effort. So we thank you for coming all the way to Malaga to record with us. Yes, and I hope this helps a lot of people.
Very well, thank you. Thanks for having me. That's right.
Guys, another episode of Better Than Yesterday to take care of your brain. I hope you make the most of it. See you in the next one. Thank you for being there, for staying to watch every episode, and for subscribing to the channel. A big hug, and let's keep empowering.